Good afternoon everybody. نورتونا جميعا وشرفتونا جميعا. It's my honor to present. It's my honor to present the Hematology Oncology session in Ain Shams University International Cancer Conference. نتشرف بيكم جميعا، نتشرف بالساده الحضور، نتشرف باستاذ دكتور محمد عبد المعطي عميد المعهد القومي للاورام، نتشرف بدكتوره سوريا عبد الحميد استاذه طب الاورام في المعهد القومي للاورام، استاذتنا الاستاذ دكتوره لبنى عز العرب استاذ علاج الاورام بطب عين شمس ومدير وحده الهيماتو اونكولوجي، وبنتشرف بالدكتوره جيهان السيسي منورانا كلنا استاذه الهيلث ايكونومكس. Now we're going to start our session with the treatment of newly diagnosed multiple myeloma patient. What is the optimal induction? By Professor Dr. Lubna Az Al-Arab.
بسم الله الرحمن الرحيم. أولاً أنا برحب بالسادة الحضور، شرف كبير جداً حضور السيد الأفاضل الأستاذ دكتور محمد عبد المعطي، برغم أن أنا عارفة مشاغله كتيرة جداً. طبعاً الأخت الصديقة العزيزة أستاذ دكتور سوريا عبد الحميد أستاذ الهيماتولوجي في المعهد القومي للأورام، وطبعاً غنية عن التعريف دكتورة جيهان السيسي. وطبعاً الإيكونومي دلوقتي يعني هو أهم حاجة، لأن أنت هتعالج بيشنت لكن without cost effectiveness without money you can't treat your patient. طبعا يشرفنا حضور أستاذنا أستاذ دكتور محمود صلاح. دكتور محمود صلاح the head of oncology department in International Medical Center. طبعا الحضور يعني the most expert in hematology أو oncohematology، فهنستفيد من خبرتهم في الحضور بإذن الله. My talk today will be the treatment of newly diagnosed multiple myeloma patient. What is the optimum induction? As we all know that myeloma أول سؤال بنسأله لنفسنا العيان ده هيزرع ولا مش هيزرع؟ بس هندي فكرة عامة عن الميلوما. It is the second most prevalent hematological neoplasm. Nearly 24,000 new cases diagnosed in US and per year, and 130,000 worldwide. The median age is 70, but in Egypt, والباناليست طبعا هيconfirm in actually the median age in our population is at least 1 decade less. Survival is increasing, but cure hasn't been realized. Clinical model for disease progression in multiple myeloma. Multiple myeloma pass from indolent asymptomatic form to active symptomatic form, and it passes through megas, smoldering, and active myeloma. And to diagnose active myeloma, we have to at least one parameter in your patient from myeloma defining effect, as CRAP, hypercalcemia, renal insufficiency, anemia, bony lesion, or more than 60% of colonal bone marrow plasma cell, serum involved light chain, more than one focal lesion by MRI, colonal bone marrow plasma cell more than 10%, or biopsy proven plasmacytoma. The asymptomatic patient presented with megas, you have the criteria for how to diagnose megas, and then it's modeling, and then newly active lesion need to be treated from first line of treatment to second line. BFS is prolonged and shortened with each relapse. What are the diagnostic tools for myeloma? Serum protein electrophoresis. Normally we have one spike, but with myeloma we have two used to detect M-spike. M-spike, it is a large amount of monoclonal IgG protein. We need immunofixation to determine the subtype of M protein present. Serum-free light chain represented at right side. We have a clonal plasma cell all make the same Ig protein and also produce extra light chain, maybe kappa, maybe lambda. Imaging in multiple myeloma وانا نايب كان skeletal survey. دلوقتي طبعا ده obsolete و replaced by low dose whole body CT وده available in all university. Whole body MRI or selected MRI for certain lesion, it's highly recommended for suspected cord compression, and PET CT recommended to detect extramedullary disease. What's the importance of staging the patient of myeloma? It's reflected, as you see by the curve on the left side. It's reflected on median overall survival from stage 1 to stage 3. It's a gap difference in survival. We have the first international staging system definition. It depends on albumin and B2 microglobin, and then revise it, ISS, which integrated the molecular biology or cytogenetic as a risk factor in staging. How to manage myeloma patient? First of all, you have to categorize your patient, transplant eligible or ineligible. To start with initial therapy, and then in transplant eligible pass to consolidation with bone marrow transplant. This subject will be tackled by Professor Mahmoud Salah, and then maintenance. But in ineligible, we treat with initial to achieve the maximum response, and then maintenance. And wait for relapse to treat the relapse situation. In all the stages, we need supportive treatment, as mentioned, that myeloma, we have CRAB, hypercalcemia, renal insufficiency, anemia, so supportive treatment is crucial in multiple myeloma patients. First, we will tackle the management of ineligible patient for newly diagnosed multiple myeloma. The first trial, it is randomized phase 3 trial, classified the patient into 3 arms. Between the first arm treated with lenalidomide with low dose corticosteroid continuously without interruption till progressive disease or unacceptable toxicity. The second arm, the same with 18 cycle of lenalidomide plus low dose DEXA. The third arm, another protocol containing melphalan, prednisone plus thalidomide for 1.5 years. The endpoint was PFS. First trial efficacy analysis revealed that continuous administration of lenalidomide make a difference, as you see with overall response with continuous lenalidomide plus DEXA versus MTB was 75 versus 62, which was statistically significant and tolerable, and with safety profile and no recommended toxicity or detected toxicity with adding continuous therapy. The overall survival after 4 years nearly comparable. Second malignancy was noted to be high with melphalan arm, so lenalidomide replaced melphalan in most scenario of treatment. Another phase 3 trial, SWAC S037, efficacy of VRD versus RT in a newly diagnosed patient without intent for transplant. It's a randomized phase 3 trial with newly diagnosed multiple myeloma with median age 63. As you know, the overall response rate was in favoring VRD and detected to be 82% compared to 72 with RT. And the median overall survival was prolonged with VRD with 30% reduction in risk of death, as well as 30% reduction in progression. VRD light, it is the same like the protocol of VRD with lenalidomide with reduced dose. It is just 15 milligram per day. Single arm analysis, it was a phase 2 trial in ineligible for transplant with newly diagnosed multiple myeloma. The median age of this group was 73 older population, so this protocol is fit with frail old patient. Overall response rate was 86 in this arm, which is great with this protocol. Maya trial was the introduction of monoclonal antibody and the DARA, which is anti-38 monoclonal antibody. This is a phase 3 trial, stressed the survival with DARA versus DARA plus RD versus RD in ineligible patient newly diagnosed multiple myeloma. As you see in PFS, we have at least 54% reduction in progression with 36 months PFS rate favoring DARA addition in comparison to the standard arm with RD. The most important point related to stringent CR. What's meant by stringent CR? It's a new term now in, it is considered as a molecular CR. It's considered as a deep response. And we can detect MRD negativity in this situation with DARA is nearly doubled, 30% versus 15% without the arm of DARA. Alcyone trial is another phase 3 trial with a very respectable number of patients exceeding 700. Again, ineligible for transplant, but the eligibility criteria restricted ASUICOC performance status equal or less than 2, creatinine clearance more than 40, and peripheral neuropathy should be equal or more than 2 should be excluded. The randomization was VMB for 9 cycles and the same protocol plus DARA. DARA was given weekly in the first dose, in the first cycle, and then every 3 weeks in the cycle from 2 to 9 with the same protocol of VMP. And then the arm of DARA received continuous therapy, 16 milligram per kg IV, monthly until progression. And the other arm of VMP, no maintenance was given. The primary endpoint of this study was PFS. Secondary endpoint was overall response rate, where overall response rate, very good partial response, stringent CR, MRD negativity, and MRD negativity was tested by NGS to the level of 10 to the power minus 5, OS as well as safety profile. With Alcyone trial, the left side detect a median follow-up after median follow-up of 40 months, 60% reduction in death, and estimated overall survival percent was favoring DARA, representing 75 compared to 62 without DARA arm. Regarding the PFS, there is reduction in progression in 58%. And you see the curve capped and the gap widen with time. Another phase 3 trial called Clarion trial, it's comparing proteasome inhibitor, which is Kyprolis. It is a second generation proteasome inhibitor, but we have Velcade or bortezomib is a first generation. So a head-to-head comparison for newly diagnosed ineligible for bone marrow transplant. As you see, PFS nearly the same, but after 30 months, the curve started to be gapped. According to response, Kyprolis containing arm is slightly more, representing 84%, in comparison to VMB 78%. The overall response favoring Kyprolis, but the most important is stringent CR plus CR slightly or numerically favoring Kyprolis arm. Regarding the toxicity, as we all know, Kyprolis has a cardiac toxicity, so the cardiac toxicity and the ischemic heart disease was reported more with Kyprolis arm, but Velcade or bortezomib, the peripheral neuropathy was higher. Tourmaline trial, this is an oral form of proteasome inhibitor called azazumab, plus RD versus RT alone in newly diagnosed multiple myeloma. It is a double-blind, multicentric phase 3 trial. Induction started for induction for number of cycles with all oral izasumab, lenalidomide, and dexamethasone. And the other arm, this was the investigational arm, and the standard arm was the same without izasumab. And then the arm received induction with izasumab, maintained with izasumab plus lenalidomide. The placebo arm maintained with lenalidomide alone. The primary endpoint of the study was PFS, secondary endpoint were CR rate, OS, pain response, and safety. The red line representing izasumab arm with median PFS favoring ISA arm with 35% months compared to 20 only with the other, with median duration of treatment 20 cycles in each arm. So adding ISA without adding further toxicity. This is representing the last version of NCCN guideline for multiple myeloma transplant ineligible patient. Category 1, as you see, bortezomib, lenalidomide, dexamethasone, as in our daily practice, and DARA plus lenalidomide plus dexa as a category 1 if we have enough money. DARA plus bortezomib, melphalan, prednisone is an also category 1. We have also lenalidomide and low-dose dexa in selected group of patients, and this protocol is also category 1. Treatment consideration in your daily practice for transplant ineligible. First of all, if you have fit patient but not eligible for transplant, please 3-drug protocol. And if you have the facility for quadrant protocol, proceed. Frail unfit, consider starting with double therapy like RD, VD, and adding the third agent. Sometimes the tumor burden make the patient frail, and with the induction of treatment, the patient improves. So escalate your therapy with the joint condition of your patient. Renal insufficiency, so you have to take care, lenalidomide dose adjusted based on creatinine clearance. Cardiac dysfunction, ابعد عن الكبرولس. and use thromboembolic manifestation اللي احنا طبعا عارفين كل عائله البروتوزوم inhibitor يعني الفالكيت في our daily dose use thromboprophylactic with lenalidomide as well as in proteasome inhibitor. Peripheral neuropathy administer bortezomib subcut بيقل جدا البريفرال neuropathy compared with IV. And consider induction with IRD. Endurance trial, it is head-to-head open label phase 3 trial comparing VRD, which is the standard, by KRD. And then maintenance, either lenalidomide for 2 years or lenalidomide until disease progression. The primary endpoint were PFS after induction, OS after maintenance. Secondary endpoint were PFS after maintenance, OS after induction, in addition to overall response rate, time to progression, and safety profile. MRD negativity were calculated as an other outcome. As you see, after a median PFS of at least 60 months, VRD and VRD in comparison to KRD, nearly the curve overlap each other or nearly equal in the first 3 years and started to gap favoring VRD. In overall, that not reflected at all on OS. Regarding the toxicity, as we all know, cardiac and pulmonary toxicity was higher with KRD, but VRD, as well as renal toxicity, VRD with neuropathy. What about the quad therapy? DARA plus VDD. This is addressed in Cassiopeia trial. It is for newly diagnosed multiple myeloma patient, open label, randomized 2-arm between VDD for 4 cycles as an induction, the same protocol with DARA. The patient eligible for bone marrow transplant with ASUICOC performance status 2 or less, very respectable number of patients exceeding 1,000, and those patients after induction by 4 cycles pass to transplant, and then those received on induction DARA continued for another 2 consolidation 2 cycle with the same protocol, either VDD or the same plus DARA, and then those patients randomized to DARA every 2 months until progression, maximum 2 years, or just observation. Another trial, which was phase 2 trial called Graven trial, also for transplant eligible patient, newly diagnosed with the same characteristic of Cassiopeia, tested DARA plus VRD compared to VRD, and induction for 4 cycles, followed by transplant and then consolidation. But the consolidation in this trial was more cycles, ranging from 5 to 6, and then maintenance DARA plus lenalidomide or lenalidomide alone for 2 years. Cassiopeia trial, what's the benefit of adding DARA? The addition of DARA to VRD improved the depth of response. As you see, the MRD negativity increased with adding DARA by around 20%. According to median follow-up of 20 months, median PFS favoring DARA, and the curve widen with time. Regarding the OS, yes, numerically favoring with a significant reduction in death by 40%. GRAVEN trial again addressed the same benefit with adding DARA increase the stringent CR. The same, but no reflection to overall survival benefit of adding DARA. That is the last version of multiple myeloma patient for transplant candidate, bortezomib, lenalidomide, and DEXA as a category 1, carfilzomib, lenalidomide, and DEXA 2A, bortezomib, thalidomide, and DEXA category 1. So by the end, I'd like to thank the panel and to thank their presence, as the panelist is the most expert professor in the field of bone marrow transplant and treating myeloma. And thank you.
Thank you so much, Professor Lubna, for this elegant presentation as usual. My question regarding the socioeconomic status, what do you recommend? Okay.
For Professor Lubna, do you think due to financial issues,
Yes.
which type of patient will benefit more from the addition of daratumumab to the induction regimen, like BTD or VRD?
Apart from financial, yes.
If you have to choose some patient to add dara for induction, which patient in our country?
In our country, we have classification according to risk factor with multiple myeloma. So I will select the high cytogenetic risk group. This is, but should be fit. DARA is an aggressive and has a very side effect. Yes, it is manageable, but we have to learn with a high cytogenetic risk group.
Now we have pleasure to introduce Professor Dr. Khalid Abdelkarim for the topic of current treatment option in relapsed refractory multiple myeloma, how to choose the regimen.
Thank you, Professor Dr. Suraya, for this introduction. And I'm so much pleased to be among this great panelists. I remember once I have witnessed collaboration work and lecture between Dr. Abdul Mu'ti, Dr. Ra'fat, Dr. Mahmoud Salah. It's like someone coming out of his comfort zone to me among the giants. So please don't go hard on me, please. So I'm here to introduce the current treatment options in relapsed refractory multiple myeloma, how to choose. Dr. Lubna introduced perfectly and took the advantage of giving a lot of data, a lot of trials. So I'll try to cut the chase to practical way of thinking about the cases. So despite the recent progress in overall survival, multiple myeloma remains an incurable disease, and almost all patients will relapse and require additional treatment. 2% of them in 60 days of treatment, 14 will relapse in a year, 84% will relapse in more than 12 months. The International Myeloma Working Group in 2015 have defined the relapsed multiple myeloma as recurrence in disease after prior response on the basis of objective laboratory and radiological criteria. More than 25 increase in monoclonal, we have seen part of this with Dr. Lubna, more than 25 increase in monoclonal protein, again, more than 25 increase in difference between involved and uninvolved serum free light chain, 10% increase or more of the absolute percentage of bone marrow, and extramedullary plasmacytoma. How to select salvage treatment? Stage doesn't affect the salvage treatment choice. What is the effect? The disease-related things like the cytogenetics, refractory disease or relapsed in less than a year, high-risk disease that relapsed more than 2 years, previous regimen related, maybe the previous regimen or the previous toxicity, mode of administration, previous stem cell transplant, the patient-related factors, the performance, comorbidities, or the patient's age. This graph was captured from a paper published by Genji Patch, I think I'm pronouncing it wrongly, in 2021, just a year ago, and it says how the role play between the different factors that affect the relapse of the patient, between the comorbidities, the compliance, the single, dual, triple, quadruple combination before the presence of refractory disease and else. For the non-aggressive relapses, we can have the biochemical relapse related relapse based on an increase in M protein, no symptoms or organ dysfunction, symptomatic relapse with slow onset of clinical symptoms with slowly increasing M protein. But with the aggressive relapses, we have, again, high beta-2 microglobulin or low albumin, presence of extramedullary disease, high LDH, short duration of response, aggressive clinical presentation, and so on. For the biochemical relapse, we described the items of the biochemical relapse before, and for the if the criteria of the biochemical relapse are not met, we can go for monitoring the patient every 1 and 2 months. But if the criteria are met, then treat the patient as non-aggressive active disease. For the clinically relapsed cases, I'm sorry, because it's, yeah. For the clinical relapsed cases, we are depending on the CRAB criteria about the calcium, the renal functions, and so on. If the criteria are met, like we are seeing here, then we should treat as more aggressive and active disease. This nice diagram can show us there is no single standard therapy or sequence for relapsed or refractory disease. If I started to say this based on trials, we can be here like for the late afternoon. So is the patient eligible for stem cell or not? Is the patient eligible? If not, then go for proteasome inhibitor, monoclonal antibodies based therapy. If yes, did the patient receive prior stem cell transplant? If no, then go for transplant. If yes, does 2 years have elapsed or not? Then go for second transplant. If less than 2 years have elapsed, then consider allo stem cell, or again go for proteasome inhibitor, monoclonal antibodies based therapy. Is the patient stem cell eligible? Standard treatment is 3-drug regimen, as we have earlier seen in the early cases. Dexamethasone and 2 of the following: proteasome inhibitor, immunomodulator, or monoclonal antibody. Immunomodulator shouldn't be received for more than 4 cycles if stem cells are yet to be collected. Patients who relapsed after a previous stem cell transplant can redo high-dose chemotherapy or allo stem cell, especially in patients who were in remission for more than 2 years. And allogenic stem cell can be tried if autologous stem cell is not feasible. Again, Another question, is patient is sensitive or refractory to lenalidomide? If not sensitive, then try the combination that we have heard from Dr. Lubna in the NCCN guidelines, the DRD, KRD, IRD, ERD. As a neuro-oncologist, partially hemato-oncologist, I spent like 4 hours yesterday to collect them one by one, and I have written them just not to recall anything worse than standing between those eminent professors. But still, we are having a lot of options. If the patient is refractory, then refractory to other agents like the bortezomib, then we have options including the DARA with other drugs. If DARA refractory, then go for KPD, VPD, and VCD. If refractory to neither of them, then the options are fewer than DVD and DPD. So is the patient refractory or sensitive to lenalidomide? A drug can be rechallenged if the disease progression occurred after more than 2 months of stopping that the drug is still sensitive. The minimal depth of initial response should be partial response, whereas the minimal duration of response should have been at least 6 months. So we are not to challenge things that was not in the first place sensitive. A disease that progressed on a drug or within 60 days that has been used in standard dose should be deemed refractory. So again, the NCCN guidelines, we have seen part of it, but for the previously treated multiple myeloma, the preferred regimens for early relapse in 1 to 3 prior therapies. If the relapse is more than 60 months, the regimen is used for, the regimen used for primary therapy may be repeated or rechallenged. For patients still sensitive to bortezomib and or lenalidomide, any of the regimens listed here may be appropriate. Most of the bortezomib refractory goes with DARA combinations as category 1, and the other way around for lenalidomide refractory DARA with other drugs like bortezomib, the carfilzomib, and dexa is category 1 for them. About the therapy of previously treated multiple myeloma, again, other recommended drugs if the relapse after 1 to 3 prior therapies, we can have bortezomib, liposomal doxorubicin, dexamethasone, and others, and useful in certain circumstances for early relapses, we can use bortezomib dexa, lenalidomide dexa. After 2 prior therapies, including immune modulator and a bortezomib and proteasome inhibitor, and with disease progression within 60 days, we can try the newer, expensive, as Dr. Abmati have been describing, the pomalidomide dexa or the selinexor, pomalidomide and dexa. At the time of first relapse, the goal of treatment at first relapse is to achieve maximum response and durable disease-free interval in patients with relapse after previous good and lasting response for at least 18 months. Retreatment with original schedule can be considered in patients with suboptimal response to relapse. Retreatment escalation to at least 1 agent that was not previously used should be considered. Continuous treatment should be considered when possible. And this comes back to the discussion I will ask the panel for them. How long can we go for this? Because I found no 2 papers say the same thing, how to go for the maintenance or the continuous treatment if I'm having the facility and the finance. For later relapses, the goal for relapse treatment is to achieve disease control and symptom release. Patients should be treated with a regimen containing preferably, lenalidomide retreatment is also feasible with and may induce response in up to 44% of relapsed patients. Retreatment with thalidomide is associated with responses up to 30%. In the trial MM003 trial, pomalidomide showed better PFS, 4 versus 1.9 months, and overall survival of 12 versus 8 months against DEXA alone, DEXA arm for heavily treated multiple myeloma patients. And this is how the 3 drugs, thalidomide, lenalidomide, pomalidomide, are chemically built, and the side effects that goes between somnolence and fatigue in thalidomide, cytopenia in lenalidomide, up to leukopenia in pomalidomide. Retreatment with bortezomib has clinical value if the patient were responsive before and if the response lasted more than 6 months. Bortezomib is effective in combination with other agents such as anthracycline and dexamethasone, where combinations can result in overall response rate of up to 80%. Carfilzomib plus dexamethasone was superior to bortezomib plus dexamethasone for progression-free survival 16 months versus 9 months in the Endover trial. Ixazomib is generally well tolerated and its safety profile is comparable with bortezomib, though with only limited polyneuropathies. Other proteasome inhibitors under clinical development, including marizomib and oprozomib, if I'm correcting saying that. And those new drugs are listed here with the route of administration and the usual dose given and the type of inhibition they are performing. Dr. Lobna have elegantly described how DARA is working, as it targets CD38, and elotuzumab is a monoclonal antibody that targets SLAM7, which is present on the surface of plasma cell. It has little single agent activity, and it combined with lenalidomide and low-dose dexamethasone showed more than 80% overall response rate. The second or subsequent relapses, for the first relapse option not yet tried, we can go for lenalidomide and bortezomib refractory for DARA and combinations. For lenalidomide refractory, but proteasome still sensitive proteasome inhibitor, we can go again for DARA combination or vedotin, not yet approved. For the triple class refractory, we can go for recently approved therapies and investigational anti-multiple myeloma agents. For both of them, we can find the CAR T cells are coming fast into the use. For the, again, for the guidelines of NCCN, therapy for previously treated multiple myeloma, more than 3 prior therapies. The Benda is there. High dose of fractionated cyclophosphamide is also there. After at least 4 prior therapies, including anti-CD38, we can go for another drugs like the belantamab mefadotin. So in addition to those therapy, don't forget that the supportive care is very much important for those refractory cases. For the bone disease, radiotherapy to be considered for, and vertebroplasty, the treatment of hypercalcemia, hyperviscosity, anemia, and infections, and renal functions. I should acknowledge my friends who have pushed me to this stage. I don't know how, but I said yes. and I should regret it. So I'm thanking to Dr. Hind Al-Azazi, a lecturer of clinical oncology who prepared most of this material, and see you inshallah in the 10th Ain Shams University ICOC 2023. Thank you so much. Dr. Muhammad, I'm still holding you to the question. What about the maintenance if I'm having the facility and the money? Please, sir.
Thank you, Professor Khalid, for this elegant, meaningful presentation up to the knowledge and up to the updated practice. Regarding your questions about the duration of maintenance, the answer is no, nobody knows the answer. But in my opinion and in opinion of other hematologists, we should try for first line after induction, after transplant, specific 3 years of, at least 3 years of lenalidomide. And most patients cannot tolerate more than that. And if, of course, if the patient does not progress within the first 3 years, he will not progress thereafter. Because the median duration of response is about, after transplant, is 4 years, the median progression to survival. Regarding the relapsed refractory patients, the answer is more difficult and more complex.
It's very complicated.
And in my opinion, there is no, in my humble opinion, there is no role of maintenance in relapsed patients. You should consolidate your patient either by allogenic transplant or second transplant, or search for novel agents which can be given after progression. And in the near future, we'll hear about the results of the maintenance therapy by exazomib in relapsed patient. I think this method of treatment, the patient is not exposed for it before, giving one tablet weekly for 3 weeks every month. It may be convenient, and we hope it will be
economically
beneficial and economic.
Thank you, sir. Thank you.
We should consider also toxicity with minimal residual disease, if applicable.
Definitely.
Although it is not the standard of care up till now, انك to consider treatment adjust او escalation او de-escalation بالminimal, لكن it has an impact introduction in the clinical research at least. For the first revision, 3 years, Muhammad said, will be enough, and I think it will be okay. I don't know if the patient did not have transplant, will you stop maintenance?
Those 3 years led me to put the last slide. During the 3 years, we will find a lot of things that will affect the life of the patient rather than the myeloma, and the patient should be treated for a vast spectrum of other disease, from the bony disease to the renal to the calcium. So I don't know, you know better.
The statement written in every guidelines until progressive disease or unacceptable toxicity.
Unacceptable toxicity. Yes.
Of course.
Yes.
Because
this is the side of it.
Patient will expose
to a lot of toxicity.
Or progressive disease.
Thank you, sir. Thank you.
Thank you, Professor. طبعا أنا برحب بالحضور جميعا واللجنة المنظمة على دعوتهم الكريمة ليا. اللي هي تحقيق تعتبر شرف ليا طبعا ابقى قاعد في وسط اساتذتي وزملائي الاعزاء. وبنتهز الفرصه دي ادعوكم كلكم جميعا لمؤتمر المعهد هيبقى في 2 و3 و4 نوفمبر. والانترستد في الهيماتولوجي احنا عندنا سيشن يوم 3 لو يوم خميس whole long day about stem cell transplant and CAR T therapy and cellular therapy. احنا عارفين الترانسبلانت دلوقتي ما اسمه ترانسبلانت بقى cellular therapy. cellular therapy ده بيشمل تحتيه كل انواع الترانسبلانت الجينيك اوتولوجاس والجين ثيرابي والكار تي سيلز والكايميريك والباي سبيسيفيك كار تي سيلز، بقى فيه كل حاجه. وعندنا يوم كامل يوم الخميس من قبل الصلاه لغايه بالليل عن الهيماتولوجي. طبعا في سيشن كامله عن الميلوما. هو از انترستد يو ار ويلكم في اي وقت ان انتوا يعني تو جوين اس 2 و3 و4 نوفمبر ان شاء الله الجاي. Next, I have the honor to present Professor Dr. Major Mahmoud Salah. General. Professor, I'm sorry. Professor Dr. General Professor Mahmoud Salah will continue the journey and he will try to answer a very important and complex question about should every patient, every transplant eligible newly diagnosed myeloma patient receive transplant or not? And we are eager to know the answer definitely. So please, Professor Mahmoud Salah.
Thank you, Professor Abmati. I hope to answer, actually. First of all, I would like to thank the organizing committee headed by Professor Lobna Al-Arab for inviting me to return back to my home. Actually, I considering the Ain Shams as my second home. I wish a successful meeting for you. Actually, this is a very important topic that in the era of this novel therapy, if there is a place for the transplant or not. So we'll see. From the lectures of Professor Lubna and Professor Khalid, you can see that the treatment of multiple myeloma is a real challenging in upfront setting and in relapsing setting because there is a lot of options for treatment of myeloma. As you can see from these slides, there is always evolution in the treatment of multiple myeloma, and there is always introducing of a new molecules that can change the landscape of therapy of multiple myeloma. Even in the relapsing setting, there is a lot of options, including a new bispecific antibodies, monoclonal antibodies, and cellular therapy. And the last decades have witnessed improvement in the overall survival from around 3 years to 8 to 10 years. More than 50 to 60% of patients can live up to 10 years in the era of novel treatment. So this disease became a more attractive disease to treat. For the transplant eligible patients, actually the auto transplant using a high dose melphalan, it became a standard of care for the treatment of transplant eligible patients with multiple myeloma for decades. And the transplant eligibility based on the age, comorbidities, and performance status. The standard age is around 65 years, less than 65 years, but for some patients, fit patients, we can transplant patients up to 75, and in the state, they can transplant at 80 years old with performance status. Auto transplant in the era of old era before novel treatment, there was improvement in the progression-free survival, overall survival for patients who underwent transplant comparing with conventional chemotherapy, which was VAD at that time, but VAD is dead nowadays. In the era of novel agents, the transplant continued to be necessary following induction therapy in today's era of effective novel agents containing IMiDs and proteasome inhibitors. As we know from the lectures of Dr. Lobna that immunomides and proteasome inhibitors became the backbone for the treatment of multiple myeloma, especially the upfront setting. So the role of stem cell transplant in myeloma has evolved in the novel agent era, and this is all the drugs involved in the induction therapy and improved in the leads to improvement of the result of induction treatment by using a triplet better than doublets, and recently quadruplet better than triplets. So transplant applied after newer induction regimen has provided further enhancement in the quality of the response and of the durability of the response. And so the novel agent and high dose melphalan followed by stem cell transplant are considering a complementary treatment strategies. This is the algorithm from the ESMO guidelines, last ESMO guidelines, which is simply exploring the patients eligible for transplantations are undergoing the induction by VRD or DARA-VTD or VTD. And after 4 cycles, he undergoing to high-dose melphalan and stem cell transplant, followed by lenalidomide treatment. This is the standard of care in the ESMO guidelines. And there is a lot of studies actually exploring the importance of transplant upfront, comparing with the conventional treatment, and so we'll explore some relevant randomization. This is important study, the GEMIMA, and the another study addressing inductions by RD. This is the doublet inductions for 4 cycles followed by tandem transplant versus the continuous treatment by the MPR or CRD. The results of both studies showed that progression-free survival and overall survival benefit was observed for transplant arm regardless of the cytogenetic risk. And patients who relapsed, this is very important, in non-transplant arm had improved overall survival if they underwent transplant at time of relapse compared with those who don't undergo transplantation. And this is providing a further evidence of the benefit of transplants. This is another study from the European Myeloma Network, including induction by 4 cycles of VCD, followed by consolidation by stem cell transplant versus VMP for 4 cycles. And as you can see from this curve, there is a clear progression-free survival benefit in the transplant arm. However, the overall survival benefit was not appeared. Both curves are almost the same. This is a very famous and important study, the IFM 2009. It's a study from the International Myeloma Group and Dana-Farber, exploring 7 patients randomized into 2 arms after 3 cycles of 3 RVD. Half the patients going to the stem cell transplants, followed by 2 RVD consolidation and 12 months lenalidomide, and the other arm receiving only 5 cycles of RVD. The results of this study showed also the progression-free survival advantage in the transplant arm. However, the overall survival was the same between the 2 arms. And this study raised the question that is because there is no overall survival benefits and there is some toxicities from the using stem cell transplants up front, we can delay transplant to the time of relapse and the patient should continue on the novel agent. So this is what the first to raise these questions. The update of this study in the ASH 2020 showed after 9 months, showed the median progression-free survival 47 months in the transplant arm, comparing with 35 months in the non-transplant arm, with 30% reduction in the risk of progression or death or death in patient receiving transplant. Also, in the subgroup analysis showed that the transplant arm is superior to VRD alone, even in patients who achieved undetectable MRD. If the patient achieved undetectable MRD, even with the VRD alone, the transplant arm doing advantage or better in the MRD rate of negativity. This is another important study. It's considering an update of the previous study. It's published in the last ASCO 2022. It's determination study, which addressing the same issue, the patient receiving VRD 2 to 3 cycles, and after that randomized to stem cell transplant, followed by consolidation by the same protocol for 4 to 8 cycles, and after that maintenance by lenalidomide till disease progression. The progression-free survival in the transplant arm showed 67 months, comparing with 46 months in the VRD alone. Also, in the risk stratification by cytogenetics showed a better outcome regarding the progression-free survival in high risk and the standard risk groups. Also, the MRD negativity by NGS showed that a better outcome in the transplant arm, around 54% achieved MRD negativity comparing with 39% in the VRD alone. But also there was no overall survival advantage between the two arms. And the conclusion of this important study that the determination finding reaffirm transplant as a standard of care, confirm progression-free survival benefit with early use of stem cell transplant in first line, and support personalized treatment based on lack of an overall survival difference to date, with the option of keeping transplant in reserve for selected patients. So, in aggregate, these studies demonstrate progression-free survival benefit with early stem cell transplantation, confirming the continued role of transplantation. And outside of the context of clinical trial, we recommend to use transplant following induction therapy for patients who are transplant eligible. Transplant eligible patients who don't undergo upfront stem cell transplantation should be offered a transplant at time of first relapse. Tandem transplant is a term that you are using a second course of high dose therapy and stem cell transplant within 6 months from the first course. And the benefit of this approach was observed in patients not achieved a very good partial remission after the first transplant. And whether tandem transplant produced superior outcome compared with single transplant has been the focus of several randomized studies. And there are a lot of studies confirming or addressing this issue. There is all the study using that as an induction, and the novel studies using the IMiDs and proteasome inhibitors in the induction regimen. And this meta-analysis revealed a superior response rate with tandem transplant with no difference in the overall survival. So the consolidation post-transplant improved response and induced deeper response following therapy, and including short courses of the IMiD or proteasome inhibitors. And maintenance, it maintained response achieved following therapy. We have lenalidomide, thalidomide, and proteasome inhibitors. And this is reduce the risk of relapse and extend the progression-free survival and overall survival. Let us exploring the consolidation following transplant. Generally speaking, the consolidation appears to improve response rate by 6 to 14%. And modify the progression-free survival by 7 months. And there has not been strong evidence that this translates to improved overall survival in the most of the study. Also, the proteasome inhibitors in the consolidations is associated with a higher incidence of adverse events, including peripheral neuropathy. This is also an important study, the stamina study, which exploring the benefit of second transplant and the benefit of consolidation by randomized patient into 3 arms after the stem cell transplant into lenalidomide maintenance, VRD 4 cycles as a sort of consolidation, and second transplant, and both the VRD consolidation and second transplant followed by lenalidomide maintenance till disease progression. At the conclusion of this study, that in the era of IMiD and proteasome inhibitors used as initial therapy for myeloma and the use for prolonged maintenance therapy with lenalidomide post-transplant consolidation with RVD or a second transplant don't produce incremental progression-free survival benefits. So all of us now, we don't use consolidation, but this study, which has been published in the ASH 2020, showed that there is some benefit using VRD as a consolidation in the term of progression-free survival compared with the no consolidation. How about maintenance? It has been approved using lenalidomide as a single agent as a standard of care for post-transplant maintenance, and this famous study proved that the median overall survival not reached in the lenalidomide arm comparing with the placebo arm. Okay, so can we do better with the longer induction without transplant? This study, the 40 trial, this is also a recent study which addressing incorporating the carfilzomab and the induction treatment. So the patients are randomized into 3 arms. First arm receiving 4 cycles of KCD, second arm the KRD, and the third arm KRD, and continuously receiving KRD in the sort of consolidation and maintenance. The first 2 arms undergoing single auto transplant, followed by 4 cycles as a consolidation, followed by lenalidomide maintenance, and the other patients receiving the KR as a maintenance. This is a new approach using double drug for maintenance treatment. The progression-free survival from this randomization showed patients receiving carfilzomab plus lenalidomide as a maintenance have a better outcome in the term of progression-free survival comparing with lenalidomide alone. The conclusion from this study, the KRD plus stem cell transplant significantly prolonged progression-free survival versus KRD for 12 cycles. And KRD plus stem cell transplant increased the rate of 1 year sustained MRD negativity versus KRD 12. And KRD significantly prolonged progression-free survival from the start of maintenance versus lenalidomide alone. The benefit of KRD plus stem cell transplant versus KRD12 or KR versus R was observed in all subgroup analysis, including deletion 17, gain 1Q, deletion 1P, and translocation 414, except in the amplification of 1Q chromosome. How about the high-risk disease and which needs more aggressive strategy? Actually, the Mayo Clinic suggesting there's a nice algorithm for that, and this is Dr. Lobna also answering these questions by using the quadruplet, including the daratumab, VRD, and the patients harboring the high-risk criteria based on the cytogenetic analysis. So this is in the middle, patient exploring harboring the deletion 17p or gain 1Q. This is a high-risk categories receiving 4 cycles of DARA VRD, followed by stem cell transplant, and this group of patients consider tandem transplant, followed by cortisone-based maintenance till progression. Also, for patients with double or triple hits, receiving the same quadruple therapy, followed by autologous stem cell transplant, and also consider tandem transplant, followed by cortisone-based maintenance treatment till progression. To summarize, stem cell transplant as a consolidation following induction therapy for myeloma remain a standard of care even in the era of novel therapy. Whether there is a subgroup of patients who benefit from tandem transplant in today's era of novel agent don't require stem cell transplant needs to be determined. For patients who relapsed more than 18 months following the first transplant and remain transplant eligible, this patient can get benefit from the salvage second transplant. Also, maintain response and long-term disease control. Despite the marked improvement in the outcome with this approach, most patients will eventually experience disease progression. This includes post-transplant consolidation maintenance strategy is used to improve long-term disease control. Post-transplant lenalidomide maintenance is the standard of care. The most important points for us is the cost-effective in the era of novel agent, even in the introduction of second-generation proteasome inhibitors and IMiDs and monoclonal antibodies or checkpoint inhibitors would delay the use of stem cell transplant till occurrence of relapse. This is not a cost-effective policy. And at least in countries with limited resources like us, stem cell transplant will remain the standard of care for patients with multiple myeloma and the first complete remission. And this I end. Thank you very much for your listening.
Thank you, Professor Mahmoud. In our situation, the second tandem transplant is effective in our cases
يعني from the real life scenario هو it's very difficult. يعني البيشنتس اللي بيخش ياخد التجربه بتاعت الترانسبلانت فيرست ترانسبلانت عشان تقنعيه ان هيعمل سكند ترانسبلانت تاني بيبقى الحقيقه صعبه جدا. دي حاجه. الحاجه الثانيه انه الحقيقه مع الافيلابيلتي بتاع النوفل ايجنتس والكونسوليديشن والمينتنس تريتمنت فبقى تراجع جدا دور التاندم ترانسبلانت. الا في ممكن لو هو عين هاي ريسك من الاول وانا ويانج وانا خلاص اقنعته بكده او he doesn't achieve a complete remission after the first stem cell. يعني لو achieved بس only very good partial remission I can consider ان اعمل له tandem transplant.
Dr. Salah, thank you. Very informative, comprehensive talk. My question related to how long can you maintain induction therapy before transplant? Yani, so long the patient is responding or you have a certain fixed number?
The standard of care, if we are using the lenalidomide and Velcade and dexamethasone, this is the standard triplet induction therapy. I used to do after 4 cycles to harvest the stem cell transplant because the continuous use of lenalidomide will affect the quality of stem cell cells. And I do the follow-up to achieve a complete response, or the deepest response that I can have, as you said, stringent complete remission, because the MRD data is still immature in this era. And after 4 cycles is the standard. If the patient does not achieve a complete remission after 4 cycles, I have to switch to another agent.
And the cutoff age? Cutoff age.
Cutoff age for transplant is 65 years old. 65 years old. This is the cutoff age, but if the patient is 70, 75 and has a good performance status, I can do transplant after full assessment للconditions.
طب انا هسال السؤال اللي احنا قلناه عشان بتاع الدكتور خالد تاني. الريلابسد او مالتيبل ريلابسد how will you maintain?
Yeah, this is a very difficult question, but we still have options for using the لو هو كان refractory على اللينيدومايد او حصل له relapse وهو بياخد اللينيدومايد up front, I can use maintenance by cortisone inhibitors, even Velcade, يا اما one of the new يعني في الترايل اللي قلت لك الكي ار دي او الكي الواحد ممكن يبقى maintenance او recently الاكسازو is a very convenient way to maintain your patient by this oral medication.
Disease progression.
Hmm?
Till disease progression.
Yes, this is the standard of care. Maybe, as you said, that the MRD risk adapted therapy will solve this problem to give a duration for the maintenance therapy and even to give a duration for the induction and for the consolidation, if I do consolidation. If I achieved MRD negativity, this may encourage us to stop this treadmill continuous maintenance treatment for the patients with myeloma.
Thank you, Professor Mahmoud. Now we introduce a very important and hot topic is about the economic burden of multiple myeloma, impact on the patient and on the society. Professor Jihan Sisi is one of the eminent names in this area of work, and we will be happy to hear from you.
Thank you so much. Actually, it's my pleasure to be with you today, and thank you for many thanks for the panel for inviting me today to talk about the multiple myeloma and how it could impact the patient, society, family, and the caregiver, and consequently the economy of the country. So today we will talk about the economic burden of this disease and how this disease could actually impact our life. Okay, if we want to talk about the symptoms of this disease, these symptoms has a different meaning in health economics. It means that these symptoms will affect the patient, will affect their family, will affect the caregivers, and the society and the economy at the same time. These symptoms means a lot. It impacts the productivity of the patient and how he can perform. So if you see now, as actually you will see that there will be increased number of the multiple myeloma worldwide. This means that there will be a huge burden of this disease in Egypt and in worldwide, across the world. And actually, you will see that the disability adjusted life years and mortality will be, or actually it's already doubled in 2019. So this means that this disease has a huge burden. So we need to allocate our resources. We need to choose the most cost-effective treatment in order to delay the progression as much as possible. In Egypt, for example, as you know, multiple myeloma is a rare cancer. Actually, it's ranked as 23 among 35 cancer types in Egypt, and number 19 based on the mortality among 35 cancer types. So in Egypt, there is the study reported that, and actually it's assessed the interrelation between the incidence, mortality, survival, and the healthcare access of these treatments. Unfortunately, they found that Egypt has the poorest outcome with the lowest 5-year survival rate due to the delayed access of many treatments. And actually, another study reported that among 217 multiple myeloma Egyptian patients found that anemia and hypercalcemia was the most common complications occurred in Egypt across this disease. So if you found actually a disease that impacts the patient productivity, you have to understand that this productivity means economy, means gross domestic product, or that this patient will not contribute to the tax revenue, and at the end it will impact the economy of the country. Another study found that 41% of the patients has a work impairment. 41% of the relapsed refractory multiple myeloma patients had work impairment. This impacts the productivity and this impacts the economy of the country. So we have to measure both cost and outcomes. We cannot consider only the cost. We cannot consider the outcomes. We have to measure both cost and outcomes to take the right decision. We have to measure the direct medical cost, like the physician visits, hospitalization, supportive treatments cost, and at the same time, the non-medical cost. For example, the counseling, the program evaluation, the transportation cost, and at the same time, the indirect cost, the productivity of the patients, which includes here presenteeism and absenteeism. Absenteeism means that this patient will not go to his work. Presenteeism means that the patient go to his work and will not perform well. So these terms is very important to be measured, to be able to take the right decision and to have the full picture before taking any decision mainly focused on the patient. So regarding the economic burden of multiple myeloma, you will see that actually the most cost component of the costs will be the pharmacy drugs or the medications. So we have to choose the most cost-effective treatment before taking any decision. We have to look to the cost-effective treatments and measure both cost and outcomes to be able to have better outcomes for the patient. And at the same time, our main objective is to maximize outcomes, not to pay less cost. Our main objective as a healthcare professional, as a healthcare team, is to maximize outcomes, not to pay less cost. So it's very important to measure both cost and outcomes. For example, we will see here in a cross-sectional study conducted in Ireland that of the participants admitted to hospital. 42% of the patients have burden due to financial worries. And actually, 66% of the patients suffered from pain. So this disease impacts the quality of life. This disease impacts not only the cost or the outcomes or the response, but actually it impacts the quality of life. And we will see here that it impacts all domains of quality of life. All domains of quality of life, including physical, role performance, emotion, cognitive, social activities, mental health, all these domains actually affected by this disease. So when we are talking about this disease, we have to take care for all the patients who suffered not only the disease, but suffer from the quality of life, the bad quality of life, the less productivity. So it's very important to know the full figure of this disease. For example, in 2019, a study conducted in Portugal reported that actually 61 billion euros was the total cost of this disease. Not only this cost, but actually it reported around 8,900 disability-adjusted life years, including years of life lost and years lost due to disability. So there is many values we have to consider before prescribing any treatment. There is many values we have to focus on before taking any decision touch the patient. For example, the productivity, how this patient could be productive and how this patient could contribute to the tax revenue and actually impact the country economy. At the same time, we have to look to the adherence of the patient to his medicine, because it actually encouraged the greater uptake in the population and at the same time improve the outcomes of his medication. And at the same time, it's very important to look to the end-of-life therapies. End-of-life therapies is more valuable, especially when we are talking about severe diseases. They have the right to take the right decision at the right time. So it's very important to consider all these values and at the same time to consider equity when there is an unmet need in a specific disease. And at the end, the value of hope is very important. When there is a medication actually provides opportunity for controlling disease and extending life, so there will be here a value of hope. So we have to consider that this patient is a human being, want to live longer, want to live better, want to live a normal life. So it's very important to consider all these values, and actually NICE and the other HTA bodies consider these values in taking any decision. Especially when we are talking about low and middle income countries or developing countries, they should measure both cost and outcomes. They cannot consider cost only. So in conclusion, we can say that cancer prevention and treatment services should be accessible and affordable for everyone. It's the right for everyone. It's the right for the patient to take his right medication and to take a cost-effective medication that provides better outcomes and at the same time affordable cost. And thank you for paying attention.
Thank you, Dr. Jian. Very informative talk.
Thank you, Professor Jian, for this elegant talk. طبعا دكتورة جيهان من فترة طويلة قوي كان لينا يعني scientific cooperation معاها على مستوى الوزارة وعلى مستوى وبعد الوزارة وعلى مستوى المعهد، وكان في publication كمان عن الهيلث ايكونوميك في الميلوم بالاشتراك مع حضرتك ومع مع الدكتور محمد خلف عن الهيلث ايكونوميكس في different lines of الميلوم. انا بس عندي سؤال فني انا مش عارف اجابته ايه بالظبط. احنا دايما في الهيلث ايكونوميك لما ازاي بتقدروا how to compare continuous treatment او continuous duration treatment with a fixed duration treatment؟ يعني ايه الاسس اللي ممكن ده يحصل عليها؟ يعني مثلا لما نيجي نقارن مثلا في سي ال ال البروتلب بالاوبنيتوزماب يعني فيروتوكلاكس مثلا، او في الميلوما حتى الار دي بالفي ار دي، او الاديشن اوف دارا بروجريشن بالفي ار دي. How could you compare this continuous treatment duration بمعانيها المختلفة؟ ممكن تقعد سنين fixed duration treatment من غير ما في بايز او في يعني تبقى fair comparison.
هو
سؤال فني انا عايز اعرف.
هو mainly احنا بنعتمد اكتر على clinical trials يا دكتور، بس at the same time we should validate these clinical trials with our local practice. So يعني at many times I think يعني you remember that we always ask the clinicians and the physicians about the local practice. So if there is different duration for the treatments, or if there is a fixed treatment duration, we consider all these aspects in our modeling or in our study, because we didn't conduct, or we always don't conduct a trials. We conduct a simulation studies. It's like يعني احنا بنظبط بنحاكي زي ما نقول simulate. We are simulating both cost and outcomes. So for example, as you said, لو البيشنت ده مثلا for example اول سنتين بياخد fixed treatment duration، لكن بعد for example another 2 years مثلا هيبقى في دوز ثانيه هياخدها، فكل ده will be considered. Any dose reduction, any dose increase، كل ده will يعني should be considered in any health economic study.
As a whole.
Yes.
A whole story, not a fixed duration.
Yes, for a long time, because the payer, at the same time, the payer want to take a decision on the long run, not on not focused on the time of the clinical trial. We are covering this patient till progression, till death. So we have to choose the most cost-effective treatment.
وانا يعني I have the same concern يعني regarding حاجه تقولي ان انت بترجعي على clinical trial، بتفوكس بقى على الاوفر اول سرفايفل ولا البروجريشن في سرفايفل؟
Both. Yes, both.
يعني زي ما انا كده في الميلوم حاجه، يعني البروجريشن في سرفايفل في حد ذاته بنعتبره اشيفي في incurable disease، فهل ده بتكونسيدر ده في الكالكوليشن بتاعك؟
Yes, we follow up the patient from from having the disease till mortality, till death. For example, we are measuring the cost and outcomes in different health states. So we have 3 different health states. We have progression free, we have progression, and we have death. So in each health state, the cost and outcomes will differ from the another health state. For example, the treatment of this progression will be taken into consideration. For example, when this patient will be progression free or progression free, and still continue on his treatment, so all these costs will be considered. So we are measuring accurately both cost and outcomes till progression, and we extrapolate the progression-free survival and overall survival for a long time horizon, maybe 10 years, 20 years, because as you said, multiple myeloma maybe could be a curable disease. So the patient can live longer with this disease.
القصة الشهيرة في بدايات خالص when the Ministry of Health tried to approve bortezomib، كانوا دايما بيقولوا لنا الفات is effective وكويس، واحنا اقنعناهم طبعا ان الفات ده بيحتاج ادميشن وبيحتاج سنترال لاين وبيحتاج هيدريشن وبيحتاج توكسيستي، العين بيحتاج بلاد ترانسفيوجن وهكذا وكذا وكذا، البي اف اس بتاعه قليل، العين بيحتاج سكند لاين تريتمنت، ربع العين بس اللي بيخش في ترانسبلانت، فايه هول ستوري يعني الموضوع مش موضوع سعر الدواء اللي انا بجيبه من الصيدليه، في تيرشري وكوارتري كوست.
فور اكزامبل برضو اكومنت على حضرتك، احنا مره عملنا الدراسه دي كانت بين 2 تريتمنتس، التريتمنت ده 10 اضعاف تريتمنت دواء جديد 10 اضعاف الستاندرد اوف كير، لكن at the same time when we conduct a budget impact analysis and see how this treatment impact the cost and outcomes of the payers, we found that this medication is cost saving in comparison to the standard of care, because this treatment will lead to progression, and we always say that progression is more and much expensive. So when we delay the progression, we are saving cost.
أنا بس عايز أقول لكم إن المجلس الأعلى للجامعات في دراسات جاريه حاليا لانه ادراج ماده هيلث ايكونومكس في كليات الطب كلها، طب وصيدله واسنان وطب بيطري، لان انا حاسس ان دي حاجه مهمه
Yes,
جدا.
very important.
يعني.
Yes.
Thank you, Dr. Jihan, for this elegant presentation. As usual, طبعا الهيلث ايكونوميك زي دكتور محمد بيقول should be integrated في التدريس بتاعنا فعلا، وهي already is integrated في اختيار الناشونال بروتوكولز لان it's very important يعني. انا لفت بس انتباهي السلايدز اللي هي concern سلايدز حضرتك كنت قلتي ان Egypt has worst survival in multiple myeloma
Yes.
بمقارنه بدول كتيره. طب ده بيزد على ايه؟ يعني هل كان ستادي comparative studies وشملت اكتر من مكان في مصر؟ وازاي احنا عملنا attribution ان السبب ان احنا عندنا الورست سرفايفل ان هو مفيش access لنيو دراجز.
In 2018, yes, in 2018 there is a study compared the survival and the outcomes of Egypt and other countries.
Head to head study يعني؟
Yes, head to head. يعني mainly head to head, but actually this study compared Egypt with other countries and see the survival and actually it measures, it compares the relation between the quality of care and at the same time the access to the innovative treatments and the survival, mortality and morbidity, and found that Egypt has the less survival. I can send you this. I can send you this study.
أقصد كلمة إن إحنا نقول a country has a worse prognosis, a worse survival دي كلمة كبيرة شوية.
Yes.
والنمبر of patients بتاع الستادي كان قد إيه؟ هل كان معمول في سنتر ولا إحنا جبنا مثلا من الستاتستكس إن السرفايفل عندنا كذا والسرفايفل في البلاد التانية كذا، فبالتالي إحنا worse. طبعا دي ما نقدرش نقول قوي إن هي it's a study إن إحنا نطلع بيها بداتا فعلية، يعني برضه عشان نطلع attribution للconclusion لازم تبقى studies population versus population، لان ممكن نقول ان بالصدفه ان البوبوليشن دي has stage مثلا late stage than other stage.
Yes.
فبالتالي عشان نقول a country لازم تبقى it's a multicentric، لازم تبقى ناخد population representative للwhole country، فبالتالي احنا محتاجين نبص على study.
Yes, I can send you the study. I can send you the reference and it compares relation between mortality and survival and the access to care. Maybe we are less access than the other countries for the innovative treatments. For example, we are talking about the public sector.
ممكن نقول فعلا ان we have less access.
Less access. Yes.
أوضح أكتر.
Yes.
يعني more informative.
دكتورة جيهان طبعا يعني حضرتك عشان مفيدة جدا فالأسئلة كتير. اوكي هو حضرتك in your consideration لما بتحسبوا الهيلث ايكونومي for any study الجي تي بي له او الدخل القومي بيبقى له reference ولا بتبقوا extrapolated من other study in nearby country ولا يعني ايه؟ بتعملوها ازاي؟
لا it's a cost effectiveness threshold. يعني احنا هنا بنقول علشان نقول على الدواء ده cost effective لازم يكون less than التوتال كوست بتاعه لازم يكون less than 3 times GDP per capita which is about 180,000 Egyptian pounds. يعني لو هو اقل من 180,000 جنيه بقول على الدواء ده cost effective. التوتال كوست بتاعه includes بقى البروجريشن الهوسبيتاليزيشن كل حاجه، مش بس الاب فرونت كوست او مش بس سعر العلبه. لو انا عملت ميجرمنت لكل الكوست دي ولقيت ان هو مطلع فاليو اقل من 3 times GDP per capita I will consider in this drug is cost effective and good value for money. But if this medication costs above the 3 times GDP per capita, this treatment will not be cost effective and should be rejected because it is above our willingness to pay. So that's the cost effectiveness plane that we take the decision based on it.
طب ازاي حضرتك بتحسبي الكواليتي اوف لايف والورك ريتيرن تو ورك او بريزنتيشن؟
It's reported يعني هو reported by الورد بانك يا دكتوره. هو mainly يعني المفروض ان 57,000 جنيه ده متوسط دخل الفرد المصري يعني في السنه. فاحنا بنتكلم لو بنحسب اليوم بكام فهيبقى اراوند تكلفته حوالي 230 جنيه ده اللي هو اليوم الوركينج داي يعني. وبنحسب الوركينج اورز وبنحسب كل ده وبنشوف بقى الامباكت على مين ليه بقى البرودكتيفيتي والابسنتيزم والبريزنتيزم. فيعني mainly this is الكالكوليشنز اللي احنا بنعملها.
Thank you, Professor Jihan. Thank you so much. Okay, and wish to see you again and again with more and more lecture about the health economy. Thank you so much. Now I have the pleasure and the honor to introduce my dearest prof, brother, colleague, Professor Mahmoud Al-Laisi. Professor Mahmoud is a professor of clinical oncology at Ain Shams University. We have in this presentation a lot of science. Now Dr. Mahmoud will present a daily life case presentation. Dr. Mahmoud, the floor is yours.
صح كده؟ اوكي. طيب السلام عليكم. هتكلم فرانكو عرب او بماي نيتيف لانجويج العربي، لان انا هتكلم براكتيكال على ارض الواقع. براكتيكال، العيان بتاع مالتيبل مايلوما لما يجي للكلينيكال اونكولوجيست في عيادته، الاول طبعا بيعدي على السيناريو اللي بيعدي على الاسيستنت اللي بيحضر الشيت بتاعه، وبعدين الكونسلتنت. العيان مستني من الكونسلتنت دون ان هو هيحل له مشكلته باقل امكانيات ممكنه واحسن افكتفنس ممكنه. علشان كده انا بتارجت في الكلام بتاعي دلوقتي الجونيور ستاف اللي هو الاسيستنت اللي قاعد معايا في العياده، لازم يبقى عارف هيطلب للعيان ده ايه وهيشيته ازاي. انا هتكلم في عجاله طبعا علشان ما يكلفش العيان كتير. الاسيستنت لازم يبقى عارف مجموعه حاجات انا حاططها اوبجكتيفز لينا. لازم تبقى عارف واتس هابينج ان يور مايلوما بيشنت، ايه اللي بيحصل في العيان بالظبط، ايه الباثوفيسيولوجي بتاعه. ولازم النقطه الثانيه تبقى عارف هل في رول للمالتي ديسيبلينري تيم في التريتمنت اوف مايلوما ولا لا. النقطه الثالثه انت كجونيور ستاف لازم تبقى عارف ايه الانترناشونال تريتمنت ريكومنديشنز وهل هي ابليكابل ولا لا في مصر. اخر حاجه النقطه الرابعه اللي مهمه جدا، لو جالك اولد فريل بيشنت عنده مالتيبل كوموربيديتيز زي الكيس اللي انا هعرضها، وعنده مثلا رينال فيلير بريزنتد تو يور كلينيك او الكلينيك اللي انت شغال فيها، جاي على كرسي بعجل زي ما حصل معايا في عيادتي. تريتمنت بلان ان ذيس كيس هتفكر ازاي لو العيان ده سوليد تيومر فيرسس العيان ده مايلوم. هنبتدي بسرعه كده للجنرال ستاف برايمنج بحاجه بسيطه جدا. الهيستوري بتاع المايلوما بدات سنه 1845 لما مريض راح لدكتور اسمه هنري بن جونز. الاسم اكيد حضراتكم بيعني حاجه عندكم. دكتور هنري بن جونز كان فاتح لاب في هارلي ستريت في انجلترا في لندن اعتقد. جاله مريض تعبان وعمال يلوز ويت، وبعدين عمل عينه بول. عينه البول دي عمل لها اناليسيس وسابها ومشي، رجع لقى فيه بروتين بريسبيتس. هي دي البنز جونز بروتين اللي هي اصلا عباره عن اللايت تشينز في اليورين اللي احنا هنتكلم عليها دلوقتي. بعد كده بدات تتوالى الاحداث وظهور الفاد بروتوكول اللي هو دلوقتي بقى حاجه يعني هيستوريكال، وبعدين بعد كده الملفنان، وبعد كده الفاد، بعد كده الثريدومايد اللي دلوقتي بقى بريفرال نيوروباثي جامد ومحدش بيستخدمه. بعد كده ظهرت الايرا اوف الليناليدومايد والبورتيزوماب والكارفيلزوماب وكل الحاجات اللي احنا هنتكلم عنها دلوقتي في البراكتس، مش بسرفايفل كيرفز. طيب لازم تبقى فاهم الباثوفيسيولوجي عباره عن ايه. هو ازاي البروتين بيظهر في الجسم بتاع العيان، ان اول ما يخش ميكروب في الجسم ايه اللي بيحصل بالظبط. بتلاقي ان الميكروب ده بيقابل في الاخر بلازما سيل، والبلازما سيل بتطلع مجموعه من الاميونوجلوبولينز اللي في منها جزء هيفي تشين وفي منها لايت تشين. طيب هل ده كل البروتين اللي موجود في الجسم؟ هل الاميونوجلوبولينز دي هي كل البروتين ولا جزء من بول كبير؟ لا، هي جزء من بول كبير. البول الكبير ده عباره عن البومين والجلوبولينز، والاميونوجلوبولين دي هي جزء من الجلوبولينز مش كل الجلوبولينز، لان عندك الفا وبيتا وجاما، والجاما ده بوليمير كتير. ده النورمال سيرم بروتين الكتروفوريسيس اللي احب حضراتكم تبقوا كلكم عارفينه. ده يعني ايه؟ ايه الشريط الاسود اللي تحت دون اللي حضراتكم لازم تبقوا عارفينه؟ الالبومين اول واحد بيظهر ويبقى سميك ودامس بالشكل ده، واخر حاجه البوليمير اللي هو الجاما جلوبولينز. لازم تبقى فاهم الباثوفيسيولوجي. ده النورمال سيرم بروتين الكتروفوريسيس. اول حاجه ظهرت لك الالبومين لان هو نيجاتيف تشارج زي بقيه البروتينز، وبيبقى بيروح ناحيه البوزيتيف الكترود، وهو اخف واحد عشان كده اول واحد بيتوجه ناحيه البوزيتيف الكترود اللي هي ناحيه رقم ايه. بعد كده يليه الالفا 1 والالفا 2 والبيتا، وبعد كده الجاما. عايز اقول لحضرتك حاجه، كل ما كان اولويه الحضور ناحيه البوزيتيف الكترود اللي هي ناحيه الحرف ايه، ده معناه ان الموليكولار ويت بتاع البروتين ده بسيط وصغير. واخر واحد التقيل قوي بيتاخر للاخر. ده معناه ان الجاما جلوبولينز هي اخر واحده بتظهر في الاخر. البيك بتاع الكيرف كورليتد بالملي جرامز او بالجرامز بالديسيليتر، وبالتالي اكتر كونسنتريشن موجود في السيركيوليشن هو الالبومين واقلهم هو الجاما جلوبولين. ده في النورمال. تعال في الابنورمال ايه اللي بيحصل؟ لما البلازما سيل تتحول لسبب ما من البناين بيهيفير للمالجنان بيهيفير، البلازما سيل دي ايه اللي بيحصل فيها؟ بتبقى عباره عن is a cell of growth not a cell of function، بتتكاثر بشكل كريزي وبتطلع كميات كبيره جدا من النون فانكشننج immunoglobulins. حضرتك هتلاقي الكيرف بتاعك اتحول للشكل ده. ده السيرم بروتين الكتروفوريسيس اللي يو كان يوز ات تو ديتكت انيشالي البيشنت بتاعك عنده هايبر جاما جلوبينيميا ولا لا. ليه البيك عالي في الجاما جلوبولينز؟ لان احنا قلنا البيك كورليتد بالجرامز بير ديسيليتر في السيركوليشن، فبالتالي البيك بتاع الجاما جلوبولينز عالي. طيب الباثولوجي بتاع المايلوما، وده اللي انا بفوكس عليه مع الاسيستنت بتاعي، لازم تبقى عارف ان المايلوما بتاثر على البون مارو، تاثر على البون، تاثر على الكيدنيز، تاثر على النيرفس سيستم، تاثر على الميتابوليزم بتاع الجسم. البون مارو خلاص كلنا عارفين ان البلازما سيلز بتمثل 5% او اقل من نسبه البون مارو، ده النورمال. الابنورمال لما تاخد عينه بون مارو وتلاقي بلازما سيلز اكتر من كده بكتير. البون بيتاثر، وبركز في الجزئيه دي على بعض الكيميكال سابستنس بتطلع من مالجنان بلازما سيلز، بركز على ريسبتور فور اكتيفيتنج نيوكلير فاكتور كابا بيتا. لو حضراتكم حد قرا في الميكانيزم اوف اكشن اوف دينيسوماب هتلاقيه بيشتغل على الجزئيه دي. دي المناظر اللي احنا بنشوفها في الاكس رايز زي ما حضراتكم شايفين. بيجي لك العيان فعلا براكتيكالي بيقول لك انا حاسس ان انا عمال اقصر، انا حاسس ان عمال ظهري بيقتب. اتقالت لي فعلا في البراكتس. الرينال اللي هركز عليه النهارده في الرينال، الكدني فانكشنز بتتاثر ازاي؟ كميه البروتينز اللي بتتكون بشكل زائد قوي من البلازما سيلز، المالجنال بلازما سيلز، البروتينز دي بتتجمع في الرينال تيوبيولز زي ما حضراتكم شايفين بالسهم الاسود، حاجه اسمها تام هورسفيل بروتين، ودي بتسد الرينال تيوبيولز تعمل العيان رينال امبيرمنت. حاجه من الاثنين هو ونصيبه، يا اما يكون الرينال امبيرمنت ده ريفرسبل، ده لو اتكون التام هورسفيل بروتين وسد التيوبيولز بس، او يكون irreversible لو التام هورسفيل بروتينز او اللايت تشين عملت انتر اكشن مع البلازما مع السيل ممبرين او بيزمنت ممبرين بتاعه الرينال تيوبيولز وعملت له دامج. نيورولوجي وميتابوليك كتير مش هنتكلم فيه. طيب حضرتك لازم تبقى عارف ان علاج الميلوما هو MTD، مفيش وان مان شو. انت حضرتك ما تقدرش تستغنى عن المعمل اللي هتتصل بيه وتساله، ما تقدرش تستغنى عن بتاع بالياتيف ميديسن اللي هيظبط لك الانالجيسكس، ما تقدرش تستغنى عن الراديو ثيرابيست اللي هيدي العيان بالياتيف راديو ثيرابي لو هو مش اليجيبل للترانسبلانتيشن، ما تقدرش تستغنى عن بتاع الكارديولوجي ولا النيورولوجي عشان علاج البريفرال نيوروباثي، ولا بتاع النفرولوجي، لان هنشوف دلوقتي ليه اهميه كبيره جدا معانا. الجايد لاينز، هل احنا في مصر نقدر نستخدمها كما انزلت؟ انا برايي لا، الاجابه لا طبعا. احنا في مصر ما نقدرش نستخدم الجايد لاينز، مش هي البدايه. البدايه لازم تسال نفسك سؤال، العيان دون سبونسرد ولا مش سبونسرد عشان تقدر تعالجه كويس. العيان لو مش سبونسرد انت هتتيلر التريتمنت على حسب امكانيات المريض او على حسب الجنرال هوسبيتال اللي انت افيلييتد ليها. يعني حضراتكم مثلا هتلاقوا الجايد لاينز جايبه لنا الترانسلوكيشنز والكلام ده كله، في بعض السنترز ما فيش فيها تقدر تعمل الترانسلوكيشنز دي. جايبه لنا حاجه اسمها مينيمال ريزيدوال ديزيز اسسمنت من نكست جنريشن فلو او نكست جنريشن سيكونسنج، في بعض الجامعات الحكوميه ما فيهاش الكلام دون. نقطة مهمة جدا ان انت في الفولو اب بتاع الميلوما لازم تركز على اي ارتفاع نص جرام بير ديسيليتر في البروتين بتاعك، it means ان العيان ده is going to relapse. لو نص جرام حتى لو انت موجود within النورمال رينج. تعالوا بقى للبراكتس. عندك عيان eligible for transplantation، البريفيرد ريجمنت هو البورتيزوميب والليناليدومايد والديكسا. This is level 1 evidence. لازم تبقى عارف الروشته اللي بتكتبها بتتكلف كام، ده definitely. كارفيلزوميب ليناليدومايد ديكساميثازون، حضرتك عارف ان الكارفيلزوميب ال 60 مللي جرام ب 18310 جنيه، ده 60 مللي جرام. وانت لو هتبريسكرايب الليفل 2A ده للعيان، انت مش هتبريسكرايب مره واحده، ده انت بتظبط الجرعه على حسب الوزن والطول، عند العيان هيقعد بقى يكمل فتره طويله. احنا بنتكلم في تكلفه علاج شهريه 80 90 الف جنيه فور هاو لونج. احنا ممكن التانيين ماشيين كده. يعني حضراتكم مثلا في البروتوكول اللي انا هتكلم عنه الداراتوموماب ليناليدومايد ديكسا، حضرتك بتتكلم ال 400 مللي جرام بتتكلف 35000 جنيه، وانت بتدي اول 8 اسابيع ويكلي، بعد كده من الاسبوع التاسع كل اسبوعين، بعد كده الاسبوع ال 25 بتخليها كل شهر. فور هاو لونج؟ تيل بروجريشن اور توكسيستي. ما حدش في مصر في الطبقه الوسطى يقدر يدفع الارقام دي. وانا بتكلم ايه؟ بند علاج الداراتوموماب بس. انت لسه بتتكلم في الليناليدومايد، وبتتكلم في السبورتيف كير، وبتتكلم في ثمن المواصلات عشان يقطع كشف ويجي لك العياده، وبتتكلم في حاجات كتيره جدا، الكوموربيدتس اللي موجوده. وبالتالي لازم كل ده should be considered انت ككونسلتنت وقاعد في عيادتك ازاي هتتعامل مع هذا المريض. العيان اللي انا هعرضه النهارده عنده مايلوما وزرينال فيلير، وبالتالي لازم اكون اورينتد قوي بموضوع الادويه اللي بتستخدم في المايلوما، من ضمنها الحاجات البون ريمينلايزنج ايجنتس. فين في الكيس برزنتيشن بقى اللي بعديها؟ طيب احنا هنتكلم براكتيكال دلوقتي. ده عيان جاي لك في عيادتك، والعيان دون زي ما حضراتكم شايفين بدايه ماي افليشن عين شمس وماي ديسكلوجر I have nothing to disclose. ما عنديش اي conflict of interest في عرض هذه الحاله. العيان جالي في العياده 67 سنه، السكرتيره مطلعاه بكرسي بعجل، بيدي هيستوري ان هو دايابيتك، هيفي سموكر، عنده كورونري انسلت، مركب كورونري ستنتس. المشكله بتاعته بدات في يناير 2021، diagnosed as chronic end stage renal failure، مركب ماهوركر، دخل لي كده في العياده فعلا، وعامل اي في شونت، مستنيين عبال ما تبتدي تبقى يعني ماتيور ويبتدوا يشتغلوا، بيغسلوا له مؤقتا من ماهوركر. فريكوينت بلاد ترانسفيوجن، كرياتينينه بادئ ب7، وبعدين مع الفريكوينت هيموداياليسيس سيشن 3 مرات اسبوعيا العيان ما بيتحسنش، كرياتينين 5 6، البون اكس بتزيد، مش اي يعني بيرفورمانس ستيتس لازال بيتشال. رغم ان البلفي ابدومينال الترا ساوند بتاعه مبينه ان بايلاترال جريد 1 نفروباثي، انما هم شخصوه كرونيك رينال فيلير واند ستيج رينال فيلير. في النص كده عدى على واحد من الكونسلتنتس بتاع الكلى، فقال لقى ان عنده الام مربحه في العظم ما بتتحسنش مع غسيل الكلى. الراجل طلب له مجموعه اكس رايز وسي تيز، لقى ان بدا يبقى فيه اوستيوليتيك ليجنز، وفي الثيرد ريب في سوفت تيشو ماس 4 في 2 سم associated with osteolysis، وزي ما حضراتكم شايفين في اوستيوليتيك ليجنز scattered all over the body. بدا يبعت للانكولوجيست اللي موجود في او الهيماتولوجيست الموجود في السنتر ده، عمل هول بادي بيتس دي زي ما حضراتكم شايفين، في abnormal fluorodeoxyglucose uptake, multiple axial appendicular lytic osseous lesions, some of them showing soft tissue component and so on and so on. السكيلتون كله osteolytic lesions. الهيماتولوجيست طلب الورك اب بتاع الميلوما، يعني طلب بون مارو بايوبسي. البون مارو بايوبسي قالت ان في مودريت انكليزيف بلازما سيلز، وريكومندنج سي تي 56 اند سي دي 138. وطبعا باين قوي في البون مارو اسبريت زي ما حضراتكم شايفين ان الكومنت البلازما سيلز 28%، الكابا لايت تشين طالعه 16. اللاب ريزلتس دي هي كمان اللي بتبقى كونكلوسيف قوي. زي ما حضراتكم شايفين اللامدا لايت تشين اليورين 122 والنورمال بتاعها لغايه 10. بالاميون فيكسيشن لامدا لايت تشين باين قوي انها رقم مرتفع جدا، وبالتالي العيان ده خلاص ده كده مايلوما. وزي ما قلت لحضراتكم حاجه 67 سنه، رينال فيلير، دايابيتك، اسكيميك هارت ديزيز، بيغسل كلى حسب راي بتوع الكلى بشكل نهائي. العيان جاي على كرسي بعجل، والعيان سبونسرد. فلما قعد قدامي، طب انت سبونسرد، هو انت ليك سيلينج او كابنج في الفلوس اللي الشركه هتدفعها لك؟ قال لي اه. السنتر انا مش انا اللي عملت كل ده، مش انا اللي عملت البون مارو ولا انا عملت كل ده، هو جالي بالحاجات دي جاهز. السؤال بقى السنتر يعني اللي انت اتعالجت فيه قال لك ايه؟ الزميل اللي هناك كتب له داراتوموماب ليناليدومايد مع استيرويدز. عنده حق، ما هو ده حاجه ملهاش علاقه بالكدني فانكشنز، اذ ربما يكون بتوع النفرولوجي يعني في حاجه مش مظبوطه، يمكن الراجل ده يكون ريفرسبل. راحوا مرجعين الروشته بالعيان للكونسلتنت ده، قالوا له مستحيل. طبعا مستحيل ليه؟ حضراتكم بتتكلموا في الداراتوموماب 400 مللي جرام في ال 20 مللي لتر 35,000 جنيه. عارفين حضراتكم طبعا انا بدي كام مللي جرام؟ 16 مللي جرام لكل كيلو جرام من وزن الجسم. العلاج continuous. nobody can afford، حتى الشركات القويه ما حدش يقدر يدفع. دلوقتي في الظروف الاقتصاديه الصعبه اللي احنا فيها، انا عندي عيانين بياخدوا اميون ثيرابي وشركات بترول وحاجات جامده جدا بداوا يسالوا هو ايه ده، الفاتوره دي جايه ازاي؟ فبالتالي انت دلوقتي confronted how to solve the problem of this patient باقل امكانيات ممكنه عشان يقدر يقوم ويمشي ويتحرك، وعلى الاقل لو ما قدرش يقوم ويمشي ويتحرك ما يبقاش بيردن على اللي حواليه، لان فعلا انا كان صعبان عليا جدا اهله وهم سايبين شغلهم بيودوه ويجيبوه. المهم انا عندي 2 بروتوكولز، البورتيزوماب ليناليدومايد ديكسا. البورتيزوماب اعتقد 3.5 مللي جرام دلوقتي من 6 ل 7 جنيه، 7000 جنيه تقريبا. ليناليدومايد ما هوش بشكل غالي يعني بدرجه، والديكسا ما فيش منه مشكله. ده نون ترانسبلانت كانديديت، لان انا طبعا قبل ما ابتدي اعالج اتكلمت مع حد من الترانسبلانتر وقلت له اعتقد انت مش هتخش، قال لي ديفنتلي مش هخش، مش هزرعه، 67 سنه رينال فيلير زي ما حضراتكم شايفين خلاص. طيب انا بفكر ازاي؟ انا بفكر ساينس. بصوا حضراتكم الاستادي دي treatment regimens for transplant ineligible patients with newly diagnosed multiple myeloma systematic review a network meta analysis. دي اتعملت فين؟ لو حضراتكم هتبصوا على الافiliations تحت انا بتكلم في Department of Hematology University في فرنسا، Department of Hematology University في اسبانيا. يعني احنا بنتكلم في سنترز ريلايبل. الناس دي عملوا سيستماتيك ريفيو وطلع لك البروتوكول بتاع الدي ار دي اللي هو داراتوموماب ريفليميد مع الدكساميثازون، هو البي اف اس بتاعه ايه مقارنه ببقيه البروتوكولات. البي اف اس بتاعه الهازارد ريشيو 0.53. يعني ايه هازارد ريشيو في بي اف اس؟ يعني البروتوكول ده قلل الانسيدنس اوف بروجريشن بنسبه 47%. يعني انت لو اديته للعيان ده هيقلل الانسيدنس اوف بروجريشن اوف ذا ديزيز بنسبه 47%. طب تعالوا للفي ار دي بتاعنا احنا بقى، بتاع الناس الغلابه. البي اف اس الهازارد ريشيو بتاعتها كام؟ الفي ار دي 0.77 هيقلل الانسيدنس اوف بروجريشن بنسبه 33%. 33 ناقص 47 كام؟ انا عارف كويس قوي ان مفيش هيد تو هيد ترايل، بس 33 ناقص 47 ناقص 33 بكام؟ 14%. هتخلي العيان ده يجين 14% in terms of progression free survival، بس هتبيعه اللي وراه واللي قدامه في بروتوكول بيتكلف في الشهر ممكن اقول لحضرتك 15 20000 فيرسس بروتوكول ممكن يكلف في الشهر اكتر من 200000 جنيه. برايي ستيل داراتوموماب مع احترامي ليهم اتس ا جود دراج ومدي ريزلتس حلوه، بس اتس نوت apparently بالنسبه لي انا في البراكتس وانا على مكتبي في عيادتي اتس نوت كوست افكتيف. بون مارو ترانسبلانتيشن زي ما بروفيسور دكتور محمود صلاح قال هو ده الموست كوست افكتيف بروسيدور. لو انا عندي عيان اقدر ازرعه هزرعه، او مش انا طبعا، انا مش ترانسبلانتر، اساتذتنا يزرعوه. حضراتكم متخيلين؟ طب تعالوا نشوف بقى الاستادي لما اتكلمت على الهازارد ريشيو ان ترمز اوف اوفر اول سرفايفل اللي هو هيقلل الانسيدنس اوف ديث. الدي ار دي اللي هو داراتوموماب كونتيننج بروتوكول الهازارد ريشيو 0.86 يعني قللت الانسيدنس اوف ديث بنسبه كام؟ 22% اعتقد، او 32%. بالنسبه لي الفي ار دي قللت الهازاردز اوف ريسك 33%، صح كده ولا انا مش شايف؟ 24. انت هتقلل الهازارد اوف ديث للمريض ده بنسبه 24% فيرسس ان هو ممكن ما يلاقيش ياكل ولا يلاقي مواصلات يجيبها لك بعد كده لو عنده حاجه يبيعها. ده الاجانب اللي بيفكروا بالطريقه دي. بصوا الاجانب بقى لما جم يفكروا، وانت حضراتكم احنا مش منتجين للدواء ولا منتجين للعلم، انا بتكلم براكتس. احنا بنستورد الدواء وبنستورد العلم. دول اللي انتجوا الدواء واللي انتجوا العلم. الاستادي دي اتعملت ان سان فرانسيسكو، واتعملت في كاليفورنيا، اتعملت في يعني حضراتكم زي ما شايفين سنترز محترمه. اتكلموا عن الكوست افكتفنس اوف ادينج تاراتوموماب or bortezomib to lenalidomide plus dexamethasone for newly diagnosed multiple myeloma patients. اقرا معايا conclusion. This study is the first analysis to directly compare the cost effectiveness of 3 acceptable chemotherapy treatment regimens for patients with multiple myeloma ineligible for autologous stem cell transplantation. ده relevant للكيس اللي انا بعرضها. Neither DRD nor VRD triple therapy were found to be cost effective versus RD اللي هو الريفليميد او الليناليدومايد دي. لا، هم بيقولوا كده، بس انا شخصيا براكتس لا، انا شايف ان الفي ار دي بالنسبه لي هنا في مصر احسن، بغض النظر بقى هو شايفين كوست افكتفنس ولا لا. انا بعرض لك الاستادي دي ليه؟ عشان تشوف الاجانب في سان فرانسيسكو، في كاليفورنيا، تكساس اند اي ام يونيفرسيتي اللي انتجوا الدواء ده هم والاوروبيين، بيقول لك عليه ايه؟ بيقول لك احنا عملنا استادي لقيناه مش كوست افكتيف، فبالتالي انت ما تقعدش قدام العيان وتعوج بقك ككونسلتنت وتقعد تقول له لا ما بشتغلش غير في الداراتوموماب. هم نفسهم قالوا ان هو مش كوست افكتيف، ما يقدروش على ثمنه. طيب انا بقى جاي لي العيان ده قاعد قدامي رينال فيلير وبيغسل، واهله بيقولوا لي احنا لينا كابنج في السبونسر شيب بتاعتنا، ما نقدرش نجيب اكتر من الفيلكيد وبالعافيه، وممكن بعد لو ربنا كرمه والكدني فانكشن اتحسنت نزود معاه لينايدومايد. انا اخترت الفيلكيد اللي هو بورتيزوماب سبكوتينيوس انجكشن، ده كان الديسيجن بتاعي. سنجل ايجنت مع ستيرويدز طبعا. بعد ما سالت البون مارو ترانسبلانتر قال لي ما اقدرش ادخل. بدات في مارس 2021 واحده واحده مع العيان دون. ربنا كرمنا فيه في 11 2021 زي ما حضراتكم شايفين بقى ترانسفيوجن اندبندنت. مارس ابريل ماي بدل ما كان بيغسل 3 مرات في مارش بقى في ابريل يغسل مرتين في الاسبوع. في ماي قالوا طب تعالى مره. على شهر 6 ما بقاش يغسل. طب استنى، طب عيد الكريات نزل بشكل دائم زي ما حضراتكم شايفين 1.09، والعيان بقى هيموداياليسيس اندبندنت. وبداوا يندموا ان هم يكونوا ركبوا له الايفي، عملوا له الايفي شانت دي، وخلاص طبعا كان شايل المهوركر من زمان. العيان بدل ما كان جاي بكرسي بعجل بقى جاي ماشي لوحده. اهله ما بقوش ينزلوا معاه 3 مرات ويستاذنوا من شغلهم، وما بقوش يقعدوا يصرفوا مواصلات، بيجيبوه زياره في العياده كل شهرين ولا حاجه. انا اتشجعت وبدات ازود الليناليدومايد للمريض ده. طب ايه بقى عمليا على ارض الواقع اللي بدا يظهر كمشكله عندي؟ خلي بالك انا لسه عندي كيدني فانكشن بالبلدي كده، انا بطبطب عليها لان مش عايز يرجع للايام الوحشه تاني ويقعد يغسل. بدات ازود ليناليدومايد بجرعات مبسطه، بس العيان بدا يظهر له هيرب زوستر، لان انا طبعا ما كنتش قادر ادي بروفيلاكسيس اجينست شينجلز بشكل كويس مع البورتيزوماب از بروتيزوم انهبيتور. المفروض ان احنا بنزود الزوفيراكس والترايميثوبريم السلفا ميثوكسازول، يعني اللي هو سبترين دي اس عشان نيوموسيستايتس. ما كنتش قادر ازود الحاجات دي طبعا لان العيان الكيدني فانكشن بتاعته مش حلوه، ناهيك على ان هو دايابيتك، ناهيك على ان هو هيفي سموكر. فاللي حصل ان جاله هيرب زوستر. لو حضراتكم تلاحظوا الجزء الاسفل من الظهر دون بعد ما ربنا كرمنا فيه وتحسن على الزوفيراكس او اعتقد كتبت الفالتريكس اتحسن جدا، ودي السكار. المفاجاه ان بعديها بشويه جاله جنرالايزد سكين ليجن زي ما حضراتكم شايفين. الحقيقه لغايه دلوقتي مش عارف دي ايه. بفكر مع بتاع الجلديه هل دي بويم سندروم؟ فيري رير. بويم سندروم ما هو نفسه مش عارف. هو ادى علاج والسكين ليجنز دي اتحسنت، يعني ده بعد ما هي اتحسنت كانت فيري ريد وجليستنينج. بس ما تمشيش بويم سندروم. بويم سندروم لازم معاه اوستيسكلورتيك ليجنز، وده فيري رير يحصل في المايلوم. اني هاو العيان اتحسن. الهدف اللي انا عايز اوصله لحضراتكم من الكيس دي هو التيك هوم مسج. For proper treatment of myeloma patient لازم تبقى عارف يعني ايه مايلوما. نمبر 2 مفيش وان مان شو في علاج المايلوما. ما ينفعش تبقى قاعد كونسلتنت وانت اللي بتعالج الكلى وانت اللي بتعالج العظم وانت اللي بتعالج الحاجات دي كلها. نمبر 3 international recommendation guidelines in myeloma are very helpful for figuring out proper treatment plan. However, some recommendations may not be suitable or applicable for a particular patient. لو جالي عيان تعاقد تبع شركه بترول وما عندوش سيلينج ممكن اكتب له الداراتوموماب ليناليدومايد وانا مرتاح وما عندوش مشكله. انما يجي لي عيان متعاقد مع بعض الشركات البسيطه والتعاقد بتاعه ليه كابنج، لا، رغم ان الاثنين ليفل 1 ايفيدنس في العيان دون. نمبر 4 best supportive care is not a proper decision for all frail patient, old cancer patient with multiple comorbidities. لما يجي لك عيان solid tumor بالمنظر ده اكيد حضرتك هتقول best supportive care versus لما يجي لك عيان مايلوما. لا، اتذكر انا كنت نبطشي في احدى المستشفيات ويل ايكويبد سنترز من 15 سنه. عيان جالي في الطوارئ وانا كنت نبطشي، عيانه ولا حته في عظمها سليمه وعماله تصرخ من الالم. حاولت ان انا كان نبطشيه عندي صعبه شويه، حاولت ان انا اوديها رغم ان انا عارف انها مايلوما موف ايتن ابيرنس في الاسكال. حاولت اوديها بتوع العظم، كنت لسه جونيور، يعني عايز اقضي النبطشيه. انا اتذكر العيانه دي انا خدتها في نبطشيتي، بعد كده الكونسلتنت عالجها دكتور محمود صلاح في المركز الطبي العالمي. انا كنت نبطشي في اليوم دون، والعيانه دي عاشت معانا 6 سنين ما كانش في حته في عظمها سليمه. فبالتالي الميلوما is a unique disease. be careful وانت بتعالجه، خلي بالك ما هوش terminal case، خلي بالك على فلوس العيان. Thank you so much.